Welcome dear doctors, welcome to 𝗲𝗵𝗵𝗺, a unique initiative by me Dr. 𝗵𝗵𝗺. I am your pediatric faculty, and in this video we are starting with the problems faced by the preterm child. See, adults present with the disease with the history, whereas kids are going to present in the OPD with a mystery. So I just want you to have your focus just like Sherlock Holmes and try to resolve the mysteries. These cute little neonates, these cute little children, they are going to bring it to you. Okay, so as I said that we are discussing about the neonatology, and this is the 5th session where we'll be discussing about the frequent problems of the preterm infants. So starting with the frequent problems of preterm, we should know who is a preterm. So preterm means the one born with before less than 37 weeks of gestation. Now see, different books write different, but nowadays as per the updated textbooks, or you can say newly updated textbooks, they say that pediatric preterm is going to be the one which is born with less than 40 weeks. Okay, born within less than 40 weeks of gestation, right? That will be a preterm child. Now, so what are the complications pediatric child faces? Pediatric child is going to have hypothermia, hypoglycemia, respiratory distress, apnea, hyperbilirubinemia, and of course the feeding difficulties. Okay, so hypothermia, of course cold temperature, hypoglycemia, low on sugars, respiratory distress, apnea, that means no breathing. Then hyperbilirubinemia, increased bilirubin, and of course the feeding difficulties. So first one, if you see hypothermia, why the child will have hypothermia? Because they have less adipose tissue for the insulation. See, understand that adipose tissue needs time to build up, and if the child is born in less than the time required, of course the adipose tissue will be less in the preterm child. So they are not able to generate heat, okay, because the brown adipose tissue is also less. So there are actually two types of adipose tissues. One adipose tissue is the white adipose tissue, other adipose tissue is the brown. White is for insulation from the cold and brown is for the heat production. So both of them are absent, that's why there is hypothermia. Of course, one more important point, they have got larger surface area to weight ratio. Okay, so because the surface area is more, of course the heat loss is going to be more quick. Okay, because the surface area is more, the heat loss is quick. Coming on to next, the hypoglycemia. Okay, hypoglycemia, see, very important, the story of stores. So glucose storage requires time. Okay, glucose storage requires time. So the main reason why preterm child has less glucose is that the stores are not fully formed. That's why the preterm child is having hypoglycemia. Coming on to next complication, respiratory morbidity. See, please understand, what happens is that surfactant is actually less, okay, because of the lack of surfactant. Understand this, because of lack of surfactant in preterm child, they suffer from closure of alveoli, that is called as atelectasis. Closure of alveoli, that is called as what? That is called as atelectasis. Right? Why? Because the lung development of the terminal sac, it is going to occur around 34 to 36 weeks, and that's why the child born less than 40 weeks, less than 36 weeks, they more have the problem of respiration, and of course that's why they are not able to breathe properly. In fact, in some cases they can't breathe even. So that's called as apnea of prematurity. Next is hyperbilirubinemia. My dear friends, preterm child, preterm infants, they don't have a proper hepatic bilirubin conjugation pathway. Okay, as you all know that bilirubin is going to get conjugated in the liver, and then it is going to get excreted. The conjugating pathway is not proper in case of preterms, and that's why, my dear friends, there is hyperbilirubinemia in these children. One more thing, there is a risk of kernicterus. Why? Please understand that if there is increased bilirubin level, it can even cross the blood-brain barrier, okay, if not formed properly. Okay, so if I talk about adults, so in adults, many adults suffer from jaundice, but this bilirubin never enters the brain. Why? Because the blood-brain barrier is very strong. Whereas in pediatric, this blood-brain barrier is not formed properly. That's why the bilirubin can enter. Can you see? The blood-brain barrier is immature. That's why the bilirubin can enter into their brain and of course causing kernicterus. Feeding difficulties? Yes. Why? Please understand that there is less oro-buccal coordination and swallowing mechanisms in preterm. These mechanisms are not developed because brain also needs time to develop. So whenever you will give food, the swallowing reflex is not functioning properly, right? Whenever the mother is giving breast milk, the swallowing reflex is not functioning properly, and that's why feeding difficulties are seen in small kids. Okay, but then the question arises, which is the best feed for them? Still, the best feed is breast milk. Okay, breast milk is still the best feed for them. Okay, so the problem is that incidence and the risk of complications of preterm infants increases with decreasing gestational age. This is something you have to keep in mind. Okay, now that's why it's very important that what will be the feeding method which will be preferred, right? Obviously we are going to give breast milk, but it should be given how? By the breast directly, or should we use some other method? So remember, if the child is less than 28 weeks, less than 100 gram, extremely preterm, the suck and swallow reflex is absent. That's why the method is total parenteral nutrition given by orogastric or nasogastric tube, but of course the breast milk is given and mother's milk. Okay, next 32 weeks or 100 to 1500 grams, then NG tube, OG tube again you have to give. All right, then 34 weeks or 1800 grams you can give cup feeding. Why? Because there is a partial suck swallow reflex which is there, so you can give what? Cup feeding can be given, that is called as 𝗵𝗵𝗵𝗵 or katori spoon that's given. And if it is more than 34, then you have to give by direct breastfeeding. So if I just summarize this for you, I told you that in order to, less than 32 weeks is going to give NG tube or OG tube. Then less than 34 weeks you have to give by katori, okay, or you can say that it is cup feeding. Then more than 34 weeks, but of course preterm less than 37 to 40 or less than 40, then you have to give by how? You have to give by direct breast milk. Okay, yeah. One more important thing, this was a very famous question which was asked in one of the central examination recently this year. So please understand that the feeding methods, okay, we have discussed, but now we are discussing how much to be given. So remember that if the patient or if the baby on day 1 you have to give 60 ml per kg per day, on day 2 80 ml per kg per day, on day 7 150 ml per kg per day. All right, now for a 1.5 kg baby on day 7, how much will you give? 225 ml per day. How will you divide it? So please understand, daily we have to feed the baby 2 to 3 times, right? So approximately understand this, either tell the mother कि हर 2 घंटे में every 2 hourly she is supposed to give the feed to baby, or tell the mother that in total you have to feed at least 10 times to the baby. Okay, and how much is that per day? So this I have written 60 ml, 80 ml, 150 ml. That's important. Okay, so until last one this was not important, but now since it has been asked in exam, this is really important. Okay, so this was about our discussion of frequent problems and little bit insight of breastfeeding I have given it to you. So thank you so much for joining. Thanks.